Thank you for joining in for yet another webinar, which is organized by the College of General Practitioners of Sri Lanka. I'm Shamla Kasim, and I'm the moderator for today. And I cordially invite all of you all, including our speaker for today, Dr. Himaru Wirithamulla, Consultant General Surgeon with a special interest in upper GI surgery. Welcome, Dr. Wirithamulla. Good evening to you.
Good evening.
And before I formally start with the introduction and to continue with our sessions, I have like few housekeeping rules. A is I urge everyone except the speaker to keep their microphones muted and to save all the questions and queries to the end of the lecture, where you can ask them by unmuting your mic or to type it into the chat box. Okay, and with that, without further ado, let me introduce our speaker for today, Dr. Himaru Wirithamulla, MBBS, MD, MRCS Edinburgh, FMAS, FCSSL. He's a proud product of Faculty of Medicine, University of Colombo, where he passed out, graduated in the year 2005 with a second class lower. And in 2012, he topped the list in part 2 of MD surgery, winning the Milroy Paul gold medal. And as I told you, topping the list. He went on to do general surgery, and he went to the Russell's Hall Hospital in Dudley, West Midlands in the UK for his foreign training. And he's back in Sri Lanka, and now he's full-time general surgeon with a special interest in specializing in upper GI surgery at RCD Central Hospital. Thank you so much, Dr. Wirithamulla, for gracing this and giving your valuable time. And he will be talking to us on lumps and bumps and ulcers, how to manage in a family medicine setup. So over to you, Dr. Himaru Wirithamulla.
Yeah, good evening. I know it's a long weekend, Vesak weekend. People have to go to, sightsee and so many things. And thank you very much for the enthusiasm shown. Quite a number had already joined. I think they are joining. I will start slow and progress. We have two broad topics to cover. They're essentially lectures on its own merit. I will try to squeeze in to 45 minutes to an hour, right? So we'll start off with lumps and bumps in general practice, right? This is a very broad topic, but we'll try to do some justice, right? So clinical approach for lumps and bumps or any general surgical condition, you look at the clinical progress of the disease and see whether it's an acute, insidious, or gradually progressing. So basically, the onset and the progression and how it came about, the clinical course is very vital, because inflammatory problems have a very acute kind of manifestation. Vascular problems are hyperacute. They immediately come, for example, an aneurysm, a symptomatic aneurysm. They also present as lumps. They are sudden. Or a soft tissue sarcoma or a lipoma has an insidious onset and gradual progression. And then pain. Pain generally is a feature of benign disease. Malignant disease are usually painless unless they involve the neural system. If there is neural involvement or neural invasion of the tumor, malignant lumps are usually silent and they don't cause pain or discomfort. That is why they are able to progress till late stages. Red flags would be, yes, prior malignancies, advanced stage, radiation is a problem, and various genetic symptoms like neurofibromatosis 1 and Gardner syndrome. Gardner syndrome is multiple polyps, osteomas, and multiple epidermoid cysts. And on physical examination, from medical school days, we look at the site size, we get as accurate as possible to the anatomical, the location, because that makes a whole lot when it comes to differentiate between the lumps. For example, midline lumps. Recently, I got a patient referred to me as a sebaceous cyst, infected sebaceous cyst. But when I saw, it was a pilonidal cyst because it was at the natal cleft, midline at the natal cleft. So it's the site itself is classic for the problem, right? So brachial cysts, those things are site specific. So the moment we know the site, it gives us the diagnosis. Size matters because size will show us how to intervene, when to intervene, and whether not to intervene, so on, right? For example, fibroadenomas up to 4 centimeters can be left alone if we are certain of the diagnosis. Then surface, whether the lump is very superficial, what the plane of the lump is, what the overlying skin is like, whether it's inflamed, and so on, and whether the surface is smooth, lobulated, bosselated, whether it's rough or so on. Shape, whether it's spherical, hemispherical, elongated, and so on. Edges, whether they are irregular, well demarcated also. That is very important because irregular margins are sometimes associated with malignant problems. Then surrounding tissue. Surrounding tissue, I mean two things. One is whether there is local reaction. That can be something like port orange, as in breast malignancy, or inflammation, cellulitis when it comes to abscess. All these are lumps, you see, that we see every day. So surrounding tissue is vital. Then plane of the lump, whether it's attached to the skin, with the arising from the skin, attached to skin in the subcutaneous plane, within the muscle, on the muscle, within the muscle, underneath the muscle, attached to the neurovascular structures, whether it is in the bone or associated with the bones. So all this is a plane of the lump. That is also vital to find out basically to find out what the diagnosis is. Skin lumps are mobile with the skin. Classic story. In short cases, we expect the candidate to demonstrate that function. Whether when we pull the skin both sides 90 degrees, then to see whether the lump moves with the skin, and the other test is to pinch the skin out from the lump to see whether skin comes off separately. Then subcutaneous lumps like lipomas have classically the slipping sign because it is under the skin, over the muscle, they slip over the muscle when we apply pressure from the side. Then fluctuation and the other thing is if the lump is within the muscle or on the muscle particularly, they get prominent when the muscle is contracted. To elicit that, we should know what the muscle underneath is and how to contract, right? So you should know the anatomy and try to contract the relevant muscle. And observe whether the lump gets prominent or hidden. If it gets hidden, it's either within the muscle or under the muscle. And if it is attached to a longitudinal structure like a vessel or a bone or a tendon, for example, a ganglion, which is sometimes associated with tendon sheaths, they are mobile sideways, not longitudinally. Right? Aneurysms I'm reluctant to move about, but still it will be mobile sideways, not longitudinal. Neuromas, again, mobile sideways, not longitudinally. So vascular structures, neurological structures, tendon sheaths, all these lumps associated with them will demonstrate a characteristic mobility pattern. And if the lump is associated with the bone, like an osteoma or a deposit or something, then they will be fixed. They will not at all be mobile. And the other thing is like a soft tissue sarcoma. When the muscle is contracted, it gets diminished because it is usually attached to the muscle because of local infiltration. So mobility will be restricted in both the directions. So those are very, very important features when it comes to physical examination of lumps. And special tests, the fluctuation is to show whether the lump is cystic. If it is cystic, then to find what it contains, we transilluminate, and certain lumps transilluminate because it contains clear fluid, such as ganglions, they brilliantly transilluminate. Hydrocele, they brilliantly transilluminate. And if the content is opaque, or if it contains blood, which is also generally behaves like opaque, they don't transilluminate. And also, classic example, sebaceous cyst, they don't transilluminate because what it contains is sebaceous material. Then cough impulse. It basically shows whether the lump is associated with something that is within, and when you cough, the pressure goes up and that pressure is transmitted onto the lump. Classic example is a hernia, where this lump is in communication with the intra-abdominal cavity, and when a patient coughs, the intra-abdominal pressure goes up. That pressure is transmitted onto the lump and you feel the cough impulse. Also, in the saphenous barracks, we feel a thrill when the patient coughs, right? Which is a lump, which is a venous lump at the saphenous opening. And if there is a meningioma in the scalp, you get a lump which is cystic in nature, brilliantly transilluminated, and the cough impulse is felt because, as you know, CSA pressure goes up when the patient is coughing, sneezing, and straining. And pulsatility, right? So the pulsatility is very important. You have to understand a normal heart rate is around 72, we say 80 or 60. So that means there is a beat per second, right? There is a beat per second plus or minus, right? So unless you keep the fingers steady on the lump for more than 2 or 3 seconds, you will surely miss the pulsatility. Because to understand pulsatility, you have to feel 2 pulses at least. And that is just 2 if you're really, really sharp. But to understand, you have to feel at least 2 or 3 pulses. For that, you have to keep the hand still, watching for the pulses to see whether it is pulsatile or not. If it is pulsatile, you have to see whether the pulsations are transmitted. That means the lump is sitting on a vessel, or expansile. That means the lump is a vascular structure. For example, an aneurysm, right? And lymph nodes, proximal. If it is malignant infection, the sentinel nodes or draining lymph nodes will be swollen, they will be palpable. If it is infected, sometimes they are tender. For that, you have to know the lymphatic drainage of regions of the body. And vessels, that what I mean is sometimes these lumps are aneurysms. So, and one of the complications of the aneurysm is thrombosis. So the distal circulation will be affected. So you have to assess that. And sometimes there, in vascular malformations, distal vessels, sometimes the venous system can be engorged. There are pictures, I'll show you. And nerves, if the lump is a neuroma, you tap on the lump, you get a shooting pain that is called the Tinner sign. Or you have to check the dermatomes to see whether the lump is causing any compression on the nerves. Now comes a few benign lumps, right? Classic one, lipomas, we see most of the time, they're soft lobulated. And now this soft means the content is not cystic, it's solid. And the consistency is, the feel is that you feel it on the, like the upper lip. And then firm is like the nose and hard is like gabella. Right, so they are soft lumps, classically a lobular surface, and it's mobile, it has a slipping sign, and it's painless. Painless with a caution, because angiolipomas and neurolipomas are painful. And they're tender, particularly neurolipomas associated with Derkham's disease is painful. And most of the lipomas do not need treatment. What we need is just patients need reassurance. But if it is either enlarging or if it is causing discomfort, like if it occurs in a flexure, whether it's associated, it's causing some hindrance or discomfort, then we can take it off, right? So if there is any problem, it needs further investigation. Now here you can see a lump which is well demarcated. If you feel it's lobulated on the surface, and slipping sign is where you apply pressure and you see this crawling under the skin, and you can pinch the skin off the lump. Then sebaceous cyst is a retention cyst of sebaceous glands, which are glands which produce a sebum, and classically they have a punctum. They also are well demarcated, and they have a punctum in the middle, that is the opening of the sebaceous gland. Content is sebum. They look like toothpaste. They're quite offensive. And there are, standard 5 complications. The commonest is infection, and infection going on for suppuration, that means abscess formation. Sometimes they lead to carbuncle formation. All those are infective complications. The other thing is calcification. Then these sebaceous material sometimes slowly discharges encrust over a period of time. That can happen and form a sebaceous horn. And the last one is coxpicular tumor, when this ruptures and looks ugly, blood, and it looks like a tumor, but it's not a tumor. That is called the coxpicular tumor. I have seen one in my life. So pilocyst is slightly different from this. It is not a retention cyst of the sebaceous gland, but it comes from epithelium between the sebaceous gland and the erector pylori muscle. They are very common in the scalp, right? They don't have a punctum, right? So they also have, and the other thing, it has keratin. It's rather firm in consistency. And we remove it along with the capsule and the punctum. Otherwise, it can recur if we leave it behind. And there are few lumps, common ones, dermatofibroma. They're very, very common in your practice. You have seen enough. These kind of lumps which are long-standing, they're not very tender. There is a classic dimple sign. I'll show you what it means. When you apply pressure on either side, it dimples, right? They can be left alone or excised. It causes concern. They are not cancerous. They don't go on to be. Ganglions are not ganglions. They are basically degenerative cysts of either a joint capsule or tendon sheath. They brilliantly translucent. Commonly it occurs on the wrist, basically. They also do not need excision unless it causes concern either cosmetically or functionally, because the underlying problem is degeneration. So excision of a ganglion doesn't solve the problem. Therefore, it can come again. That is why it has a recurrence rate of approximately 20%. So 1 in 5 cases come back. So unless the problem cause trouble to the patient, we just reassure and leave them be. Pyogenic granulomas again is a very, very common problem that we see in our day-to-day practice. This, after a small trauma, trivial trauma, the wound healing process gets deranged and there's excess granulation tissue formation. They are benign, but they're troublesome because they bleed easily, because it contains granulation tissue. Granulation tissue is epithelial histiocytes and capillaries, newly formed capillaries. They are unstable, so they bleed with trivial trauma. So we can either cauterize with electrocautery, or we can excise. I generally tend to excise and suture, right? Then neuromas. Neuromas are twofold, either acquired or acquired like this Norton neuroma. Sometimes it happens, it commonly happens between the toe clefts. They are painful nodules when walking, and treatment is excision. Or else after trauma also patients can develop neuroma, particularly after amputations, right? That is a known place where they develop neuromas. They are tender, painful, and it classically shows the tinner sign. When you tap, it gives pain that gets shooting on the nerve distribution. Aneurysms, we should never forget. These are popliteal aneurysms, right? The commonest are abdominal, but fortunately, aneurysmal disease is rare in this country, but in the West is quite common. Abdomen, popliteal, carotid, and then femoral. There is the order in and out. And you have to keep in mind whether these are aneurysms. And the other thing is, in the popliteal area, there's another cystic lesion, which is called the Baker cyst. It's a degenerative cyst of the knee joint capsule. In osteoarthritis and all, patients develop a cyst there, which is mostly silent. Sometimes they break, and that causes inflammation, and that sometimes presents something like a thrombosed aneurysm. So it causes severe pain. And the other thing is DVT also, it can cause confusion because once it breaks, it tracks down and causes swelling and pain in the calf. Vascular malformation. Now here it's a beautiful short case. Now this sometimes I have seen this where some, you've seen fishmongers and some carpenters use their palm to hit at nails, sometimes the knife blade, the reverse of the blunt surface of the knife blade to apply pressure. Sometimes when they do that, the small vessels, arteries and veins rupture and they form a malformation. And that gives a hyperdynamic circulation. Because of that, can you see all the veins are engorged? And there's local gigantism. The fingers, look at the fingers, these fatten and these also fatten. That is because increased blood supply to that area, causing local gigantism, engorged veins, because there is hyperdynamic circulation. Now, vascular malformation can be arterial, capillary like capillary hemangiomas, or venous, cavernous hemangiomas, right? And they classically empty when you apply pressure, they empty. Arterial malformations make the area warm and pulsatile. This again is a very, very common presentation where not very often diagnosed properly and mismanaged. Hydrogenated suppurativa is a problem of the apocrine sweat gland. And it's basically autoimmune kind of inflammation of the apocrine sweat glands. So wherever you get apocrine sweat glands, patients can develop these problems. So it is common in the axillae and the groin, right? Commoner in the axilla. associated with obesity, smoking, so on, right? And they cause recurrent inflammation, abscess formation, sinus formation, and it's quite disabling. So the treatment is dermatological. When I get patients, I teach them what the problem is, and I refer the patient to a dermatologist. And because they need follow-up, these problems do not cure, because unless we take the skin off and do a skin graft, which is a definitive treatment, um, it keeps coming back, and its treatment is essential dermatological. Surgeons do get involved if they form abscesses, right? And this picture is classic, right? So this picture, a patient comes with a lump which looks rather angry. Yeah, looks rather angry, and it looks like an abscess. And there are few nodules here also, which gives suggestions that it could be hidradenitis suppurativa and an abscess also. We generally tend to incise and drain this. But in the flexures, always remember the axillary vein, the axillary artery, they are quite close by. So we have to have a caution when we make incisions or in flexures, right? The best way is to put a needle, aspirate to see whether it brings out pus or blood, right? A dry aspirate is all right, because sometimes this pus is coagulated. So it doesn't come into a small needle. So if it doesn't gush blood out, you're safe to make an incision. Alright? And as general practitioners, yes, you can do it under local anesthesia is possible, but first aspirate. Second thing to assess whether we can give local is the surrounding tissue. If the surrounding tissue is not inflamed, it can be, and if it is of acceptable size, it can be done under local anesthetic. We do not give local anesthetic if there is surrounding inflammation. Why? Because the surrounding area is inflamed, the interior milieu is acidic, and the lignocaine dissociates into ions and it doesn't work. So there is no point in giving local anesthetic to an area which is inflamed. But here there is no surrounding inflammation, so we can give a field block here and make an incision which is parallel to the vascular structures. After incising, make a lavish incision, saucerize the skin edges, so the skin edges are kept open. Put the finger in, break all the loculi, and wash thoroughly with some saline. You can use peroxide, may or may not, that is optional, but wash thoroughly with some saline. And the other thing is vital is to take a sample for culture, because now these patients now in this day and age, they've been to multiple doctors. Sometimes they self-treat, sometimes the pharmacist treat, and they have been on antibiotics. So the bug may not be sensitive to the antibiotic we usually prescribe. So it's always good to take a sample for culture. Soft tissue sarcomas, the red flags. If a lump is more than 5 centimeters and is gradually or recent rapid enlargement is a warning sign. They are usually fixed because of local infiltration, and pain is a symptom of neural invasion, right? The important thing is, in soft tissue sarcomas, we do not biopsy until we finish imaging. Reason is, these biopsy needles sometimes cause hematomas, sometimes cause infection, sometimes cause inflammation. All that changes the image, and we cannot differentiate, the invasion and so on and so forth. So imaging is the first, and then comes the biopsy. Biopsy is also, the types of biopsies. We can do the needle biopsy, co-biopsy, incision biopsy, excision biopsy. Of the lot, if we are worried about a soft tissue sarcoma image, then the best thing is excisional biopsy according to the oncological principles done by people who do it regularly, because it's a nasty disease to have. So first surgery is the best surgery. It should be done by people who are doing it regularly. And imaging, ultrasound is a good starting point, but soft tissue sarcomas need MRI. Okay. And now this is a soft tissue sarcoma. It looks like an abscess, isn't it? But it is wrong because there is tumor breakdown. All these things are happening. So there is a degree of inflammation. There is new vascular formation. There is red, it blanches. But if you listen and if you go through the history, it's a slow progressing disease. Right? So it's not like an abscess. Abscess, the patient tells this was not there. It started either an insect bit or there was local trauma or some starting point. From that, within days, it became something like this. But this goes on for weeks, if not months. All right. Ultrasound is a first line for most other tumor lumps, and MRI reserved for cases which you think is soft tissue sarcomas. So primary care, what you can do. So you have to understand the anatomy, what you are dealing with, whether these lumps are associated with neurovascular structures. So neck lumps, for example, a classic example. When I was in SH, I was SH at Pandura, right? So we used to do lymph node excisions under local anesthetic. I used to do, right? I was quite confident. And in fact, I sometimes mocked at people who required general anesthesia. That is because I was junior. So I became a consultant, or even an SR. Then I understood anatomy better. I understood the implications. And if it started to bleed at that level in the neck, panic sets in, patient starts moving, and it's a soup. So now for lymph node excisions, I always require general anesthetic. So with time, we all learn. Consent has to be documented. Just even if you're in a GB practice, it is vital that you take written consent. And in that, you have to tell what the problem is, what you're going to do, what is the intended benefit, what are the possible complications, right? So all that you have to document and take a written consent, because the patient can always challenge that you have not told and can take legal action. And such legal action, though they're rare in this country, if occurs, can cost all your life's earnings. So it's not really worth it. Histopathology, I generally send all lumps involving the face, hands, and feet, because those areas you get tricky stuff, right? Like, for example, amelanotic melanomas. So they are not classically black in color. So you get all sorts of funny things in the feet as well as hands and the face, right? Basal cell carcinoma. So always those things I send for histopathology, even though the diagnosis is quite obvious. Other sebaceous cysts, other areas sebaceous cysts, I don't. I throw them if I'm 100% confident. But histopathology is a defense, very good defense for us. Because I had a patient who came with what looked very much like a wart on the sole. I excised it. Because it was from the foot, it was very much like a wart or a callosity. I sent it for histology. And for my luck and the patient's misfortune, it came as a callosity. So I reassured the patient. And but the wound didn't heal. So he went to another surgeon who had biopsied to find that it's a melanoma, ameliorating melanoma. So I had defense because I have done the right thing, right? So nothing happened. I explained this is what I have done the correct thing. I have taken and sent it for histology. This happened. But anyway, you're in good hands, and he had done the block dissection. The patient is all right. So histopathology, don't take it lightly. It's very, very important. So I think I have spoken just beyond half an hour. We have 15 minutes, kind of half an hour to 15 minutes to half an hour to talk about wound healing. Now, we must understand wound healing is first and foremost, are you all following me? Somebody?
Yes, sir.
Yes, sir.
All right, great. Thank you. Otherwise, I'll be talking to myself. Oh, thank you. Wound healing is the rule. Chronic wound is the deviant, right? So we have to understand. So what we have to do is to support wound healing that nature does for us, right? So we have to understand the phases of wound healing, identify the factors that affect wound healing, and define chronic wounds, and learn how to assess wounds and how to deal with them, right? And wound healing, we call when it is completely, we call a wound healed when the skin completely covers the wound and stays on for more than 2 weeks and in 2 consecutive weeks. This is basically, right? Without a discharge, there is complete epithelialization that we conclude it's a healing wound. And you can see the stages of the wound as we go on, and also good practice to photograph the wound. Photographing again is cautious, right? So clinical photographing doesn't exist much in this country. So unless we use a professional medical photographer with consent, it can be challenged because they can always call, we are breaching their privacy. The trick is use their phone. Most of these people carry a smartphone. So I use their phone to photograph the image, and 2 benefits. So I stay off litigation. 2, the patient has a picture. 3, patient has a record. So, and the record comes along with the patient. So I don't have to search in my gallery. So that's a trick I do for most of the patients, not only wounds, other things also. And also sometimes when we examine, if I don't have the torch by the side and if I need a light, all phones have a light, and I get the patient's phone and use the light, not my phone, right? Because they can always claim that I've taken pictures, right? So be mindful about that. So wound is a deep disruption of skin integrity. There are acute and chronic wounds, and it causes a significant burden. So much so that people can develop a complete practice based on wounds because it's mismanaged to a great extent. Acute wounds are acute, like surgical wounds, traumatic wounds, and so on. Chronic, when they do not heal, the complete epithelial coverage that stays on for more than a month or a month and a half, we call them chronic wounds, right? So the problematic chronic wounds would be diabetic wounds, venous, arterial, pressure ulcers, and malignant wounds, which I have not mentioned here. So phases there are 4 phases: hemostasis, Hemostasis, when the skin is cut, the vessels are also cut, there's blood, and blood clotting cascade starts, and clot plugs the wound, right? And that triggers off inflammation. All the inflammatory mediators, the cytokines, the macrophages, everything, neutrophils, all that comes and triggers an acute inflammatory process where bacterial phagocytosis happens. Sometimes more debris, they get cytosed, so all the cleanup process occurs, inflammation. And once inflammation settles, comes proliferation, where granulation tissue is formed, right? So the granulation tissue starts forming, where new capillaries form, and epithelial cells come in, and fibroblasts form fibrin, and develop granulation tissue, and it starts healing. And on the top, epithelial surfaces start migrating, and complete epithelialization occur unless there is a problem within 48 to 72 hours, right? So surgical wounds, surgical wounds are done in the theater and done in controlled circumstances without infection. And generally speaking, after 72 hours, they cannot get infected in theory, unless there has been some contamination, right? So all this happens, angiogenesis, all this, right? And then tissue remodels. The granulation tissue matures and it forms into a scar. Scar remodels and matures and it contracts, right? So this is what happens in wound healing. Healing becomes a problem if either of these stop progressing onto the next level. If the inflammation is more and it doesn't go into proliferation, there is a problem. If there is excessive proliferation and it doesn't go into tissue remodeling, there is a problem. If there is problem of hemostasis, then there is a problem. So all these stages can give rise to problems. So we have to understand the underlying physiology and address. Once we address, it becomes a piece of cake. So hemostasis is immediate. This is very easy. I will quickly brush through. So it brings on platelets. Now platelets, as you know, is a factory, or it's a storehouse of growth factors and cytokines. They release all that and starts off inflammation. In a normal case, it's done within 72 hours. By the end of inflammation, the epithelialization is complete and all the debris, bacteria is taken care of. And then fibroblast comes in and lays the granulation tissue, and collagen deposition occurs. Angiogenesis, that is new formation of capillaries. Granulation tissue, as I told, all this forms, and scarring starts, and then remodel, scar maturation, and the wound starts contracting. At the end, the scar has a tensile strength of approximately 80% of the healthy native skin. So as I told, these are the processes, right? So factors affecting wound healing, classic question. I think we all know there are local factors and systemic factors. We have to deal with both, right? So infection, if there is prolonged infection, or if there is a problem with perfusion, because blood flow is vital for wound healing. If there's excessive edema, it causes a lot of exudation and transudation. So it interferes with cell migration and healing. If there is recurrent trauma, so whenever it heals, it gets traumatized. So then again, the wound healing gets delayed. Presence of foreign bodies. If the wound is dirty, right? If there are pieces of foreign bodies inside, that can cause trouble. And the other thing is malignancy, local malignancy. And certain infection that start off chronic, for example, syphilis, TB, they don't heal, right? So from the outset, the inflammation is chronic. It's not acute inflammation. So then that's a problem. Systemic factors would be diabetes. Diabetes is a global disease. It causes so many problems, including immunosuppression, then vascular implications, and neurological implications. All these have deleterious effects on wound healing. Malnutrition, twofold. We need proteins to heal, and micronutrients such as zinc is vital for wound healing because they are important components of metalloproteinases, some enzymes that help in healing. Then obesity itself is a disease. And there is derangement of so many things that work in the body. Smoking affects the vascular system, so there is lack of blood supply to the area. Advanced age, basically in advanced age, cells don't replicate that quickly, so healing gets delayed. And medication, particularly steroids and chemotherapy, delays wound healing, and radiation, again, we know wound healing gets delayed, right? So chronic healing, chronic wounds happen because the problem, the healing doesn't progress on through stages, right? Okay, so there is persistent inflammation in that area. There is exudation, slough formation, and it doesn't heal, and there is prolonged inflammation. And biofilm is a film basically formed by bacteria. They are not that is not infection, that is colonization, right? So they stay on, and it perpetuates the inflammation. So we have to get rid of the biofilm. There are so many ways of doing it. So wound assessment, as I told, photography is important. And we have to make note of the size, the depth, the location of the wound, the amount of exudate it brings out, and the tissue type, right? What is involved, whether it's muscle, the bone is exposed, the tendons are exposed, and so on. What is the order? The classic order of Pseudomonas. The moment somebody opens the wound, and if it gives the classic order, Pseudomonas is there, right? And whether it causes pain and so on, right? And time is mnemonic, TIME, tissue, infection, moisture, and the edge. So these are the things that you have to address, right? So in the tissue, there is a color model, right? Pink is good. Pink shows all epithelialization, right? Red is granulation tissue. Yellow is slough, and black is necrotic. So we have to get rid of whatever that is not red and pink. Okay, so whatever that is yellow and black has to go out, right? So red, yellow, black, and pink. Okay, so that is called the color model of tissue assessment. And in that, we have to check whether the tissue is viable or non-viable. Same, in other words, right? So all non-viable tissue, the black and the yellow, has to go. So to that we can do surgical dead removal. So sharp excision of all the dead and the necrotic material. Autolytic, we use phagocytosis of the body. For that, we have to make a moist environment and get the phagocytes of the body, macrophages of the body, to eat up all the muck, right? So for that, you have to put a hydrogel and cover it with a primary dressing and allow it to happen, right? So it is important when surgical debris removal is tricky. Then enzymatic debris removal is also present, where we use exophytic enzymes to take off the dead and devitalized tissue. The other one is maggot therapy. So maggots, eats all the dead tissue. So maggots take off all the devitalized black and yellow stuff, right? Infection. Now, important thing is we have to identify what is infection, what is colonization. Now, when we take a wound swab, it will grow whatever that grows. So it will identify the bacteria that grows, and then it will show whether it has pus cells or not. Presence of pus cells means there is inflammation. Presence of bacteria plus inflammation equals infection. Presence of bacteria is colonization. So colonization technically does not need treatment, but it can give rise to biofilms. So that has to be dealt with, but not so badly. So we have to take a swab or tissue biopsy, basically the dead tissue, for tissue culture, and then topical versus systemic antibiotics. Avoid topical antibiotics, but Metrogel is metronidazole given topically. That is okay, that is acceptable, because it helps with preventing the odor of the wound. So that has a separate special role, but generally speaking, I try to avoid topical antibiotics. Antiseptic is a different story. I am quite fond of acetic acid. 1% or 3% acetic acid takes off Pseudomonas, which is a very common colonizer. And systemic antibiotics, if the wound swab comes off positive with pus cells, or there are cardinal signs of infection, which is redness, pain, exudation, loss of function, and so on. And biofilm control, I explained earlier. And moisture, we have to take excess moisture out, but we should prevent desiccation, right? So the wound should be just right. So that balance is vital, because if there is excess exudation, it causes maceration. So maceration is not good. It takes the epithelium off and makes a wound bigger. So edge advancement is epithelial surfaces from the else periphery comes in, right? So you have to get the edges right, and healthy healing edges are sloping. So when we describe edges of an ulcer in medical student days, we have to be specific whether edge is sloping or not. So other edges are rolled edges, that is seen in basal cell carcinoma, undermined edges, that is seen in syphilis and TB, right? Punched out edges, which are seen in vascular ulcers, right? So, and everted edges, that is seen in squamous cell carcinomas, right? And this I have dealt with now. And options are, and basically we see whether the edges are coming in, and edges are not advancing, and the base is nice. Now at this time the base is okay, granulation tissue is there. It's just that tissue epithelialization doesn't come and epithelial cover doesn't occur. Then we have a place for skin grafting, right? So this is the time protocol, right? Tissue infection, where is it? Moisture, and exudate, right? An edge, actually, ESH, right? So we have to document like this. So it's handy to have something like this in your practice, and you can tick off. So dressings, vital topic. I think the most important area of the lecture, right? So dressing should do few things. It should absorb the exudate. It should keep the wound moist. It should prevent trauma. It should prevent bacteria coming in and colonizing. And it should take off excess cytokines and should promote healing, right? So that is what an ideal dressing should do. So gauze is good to absorb exudate. Hydrocolloids again absorb exudate. Hydrogel keeps the wound moist. You should not put hydrogel to a moist wound. Too much. If there is too much moisture, it will cause maceration. Foams again absorb moisture. Alginates at different levels, it absorbs moisture. Then silver prevents bacterial overgrowth. Iodine prevents bacterial overgrowth, but mind you, Pseudomonas proliferates within iodine, so it is of questionable use. Honey has a load of so many antibacterial, so it absorbs excess moisture. We know that it's a desiccant, and it provides a healthy environment for wound healing, and it provides antibacterial action also. And films to keep the wound, to seal the wound, keep it moist to prevent desiccation, right? So I told you. So films like abrasions and stuff, we keep it covered to prevent it from drying off and to prevent infection, and basically till epithelialization completes, you just cover it from prevent and get it infected. Silver and iodine is used for infected wounds. Alginate and foam, I told, take off exudate. Hydrogel prevent desiccation. It provides moisture to a wound. Same thing. Negative pressure therapy. This I love. It promotes healing, promotes fibroblast migration, and takes off cytokines, excess cytokines, and deals with the ongoing infection. But few cautions. If a patient has critical vascular disease like occlusive arterial disease, it can steal blood. So we don't use it in that kind of situation. But otherwise, I love it because it quickly promotes granulation tissue and gets the wound to a position where we can do a skin graft and conclude the process, right? And there we keep it at around 125 minus millimeters of mercury. It can be given as continuous or intermittent negative pressure. Diabetic, now few conditions, diabetic, venous, arterial, and pressure, right? So diabetic is a neurovascular leg. There are problems of lack of blood supply. So it shares problems with arterial ulcers, and it shares problems with trophic ulcers, like neurological ulcers, where there is problems with weight distribution and recurrent trauma, right? So diabetic foot, and the other thing is because of lack of immunity, those wounds can get infected and the infection progresses onto sepsis. So we have so many problems going on in diabetics. So we have to sort the problem. And all these patients, arterial ulcers, diabetic ulcers, trophic neuropathic ulcers, and any ulcer should not bear weight on the wound. So offloading is vital. My trick of offloading when it comes to feet is now it's very difficult to get them, but there is a local brand called Beta, local shoe called Beta, where the insole is pasted with Velcro. So you get the foot, the sole, and there is an insole which is pasted, and there are straps both ways, right, to the heel and on top, right? So what I do is I get the patient to bring it and take the insole off and cut a big wide circle at the place where the wound is and give it to the patient, and then stick it back on and get the patient to wear most of the time during the day. Then this effectively offloads the wound and they heal in no time. And when the wound is healed, they can take that portion which I removed, stick it back, and the shoe is quite wearable. So that is something I do. But unfortunately, these beta sandals are very difficult to acquire. They go off suppliers with many things in this country, unfortunately. And all this I have told. So venous ulcers, there are two schools of thought. One school says you have to treat the ulcer. The others one says you have to treat the underlying disease. I belong to the school where you have to treat the underlying problem. Otherwise, this is not going to settle. So luckily, when we were training, laser varicose veins were not done. Now it's there. So it's much less invasive. I don't do it, unfortunately, because I was not trained. But either open surgery or laser or even strapping, either ways, you have to deal with the underlying problem. Unless we deal with the underlying venous disease, the ulcer is not going to heal. So do both in tandem, right? And arterial ulcers, you have to please feel pulses, which not many people do. And I've come across so many patients getting treated on and on and on and on, where proper vascular, just pulse chart is not there. So a simple pulse chart does, and ankle brachial pressure index and so on. But for that, you need the Doppler, which you don't have at their practice, but just a pulse chart should do. And arterial ulcers, or if you're worried about vascular supply to the wound, never apply plasters across. Apply plasters along the vessels so it doesn't cause compression. Right? So if you get the foot like this, where is it? Foot like this, you apply the plaster longitudinally, not transverse. Transverse plasters cause compression. Right? It gets blurred. Anyway. Right? So you take it, put plasters longitudinally, right? So the vessels don't get compression. And the other thing is, I never use cotton bandages. Cotton bandages are restrictive, particularly when they are wet. So the moment cotton bandages are wet, they are compressive. So I don't use it. What I use is Fine Tex. That's a brand, sorry, but that is what I use. And it is elastic. So if the underlying limb or the structure expands, swells up, this gives way. And it is dynamic. It can either expand or it can contract, but it never cause compression, right? And and the other thing is pain control. Arterial disease has critical limb ischemia. So they have to be dealt with, otherwise it causes quite debilitating pain. Pressure ulcers need few things. First is repositioning. They have to move either ways, and they have to be nursed on a air mattress. So it's vital for you all to understand the patients and the family need to buy an air mattress. I tell the patients sometimes we deal with high risk for pressure ulcers. I get them to buy an air mattress on the way home. No questions. So otherwise they get into this mess, which is very difficult for them to come out, because those patients are like that because they can't move. So that's vital. And nutrition is another problem. So they are usually malnourished. So nutrition, which includes high protein and multivitamins. And micronutrients like zinc is vital. And then the skin should be, the ulcer should be covered with a barrier lotion. Zinc oxide base is classic for this problem, for this issue. So it basically covers the wound and prevents contamination. And the other thing is prevention of fecal contamination. That is also because this occurs at the commonly occur at the sacrum and on both the ischial tuberosities, rather femoral greater at the edges. So fecal contamination and urine contamination is quite common. So the patient and the bystander or the caretaker should be warned to prevent fecal contamination. There are several ways of doing it. Either a stoma. So that stoma I love because stoma diverts fecal matter completely. And these patients who are with limited mobility, nursing is also a problem. So nurses can easily change a colostomy bag and wound heals in no time because there is no fecal contamination. So people do not like, unfortunately, but it's okay. Those patients should be, the bystanders should be told basically to clean and to prevent fecal contamination of the wound, because it doesn't cause infection, but it causes colonization and prolongation of inflammation. And nutrition, I told, protein, vitamin C, zinc and hydration. And it's always nice to train some people. So you form a team, and patients benefit from the team. All right, I just went beyond. I think I kept to 1 hour. Thank you.
Thank you very much. We are now open for questions. Does anybody have any questions for Dr. Wirithamulla? I think there was a chat.
How can I access chats?
No, I'm trying.
Here it is.
Yeah,
I got
yeah,
it.
yeah.
So, wound with excess granulation tissue, how would enhance it? Good question. Now, excess granulation tissue, right? So, all right. So excess granulation tissue means the wound is stuck on proliferation, right? Next is epithelialization. So a few ways to deal with. If there is excessive granulation tissue, we can reduce the granulation tissue classically with use of copper sulfate. You can sprinkle copper sulfate, that will destroy some granulation tissue back to normal. That is a simple way of doing it. Or the other thing is to shave the excess granulation tissue and to put a skin graft. That solves the problem. Oxyferin, I have not used for 10 years, I would say. Honestly, I haven't used. I used during training, but not afterwards. I deal with a lot of wounds, but I have never felt the need for it. I go for simple things. Now, most of the wounds, when I get a pressure ulcer or any leg ulcer, I would say. So, if I get a patient, I always feel the pulses. Then I assess the location, anatomy. Where is it? I see whether there is pressure. There is a problem with pressure distribution, or whether the wound is on a pressure point. Then I look at the wound and see what, the standard stuff, whether there is excessive granulation or whether there is slough, whether there is exudate, and so on. And then I take off all the yellows and blacks. Classically, surgical debris removal. Use a fine scissors, fine tooth forceps, and take off all the necrotic tissues. And then always offload. Without offloading, I just don't treat because there is no point. Then if there is excessive, usually there isn't excessive exudation. So if it is desiccant, we use hydrogel. That's a different story. But most of they need some kind of moisture. So hydrocolloid is nice to have. There is a locally produced product. Sorry, I'm using products because whatever it is locally produced, right? Fendazil, right? These guys are from Panadura. They produce various wound care products. It's nice. It has ionic silver and it is a hydrocolloid, and it gives moisture and prevents the wound from desiccating, and it provides moisture as well. Then put gauze as a primary dressing, then bandage or plaster as a secondary dressing. That is one way of doing it. The other way is, other common applicant is acetic acid. I love acetic acid. Acetic acid, we have to change the dressing every third day. Hydrocolloids, we can keep up to 5 days, right? Intrasite is another hydrocolloid. It's more expensive. That I have used sparingly. But now I'm a fan of this Fendazil. Because it's just right and it's local Sri Lankan products. So that's it really. And I've been lucky. So I identify what is the problem and what stage the wound is held. If it is infection, I have to deal with infection. If the problem is lack of nutrition, I have to deal with and the other thing, I ask them to eat eggs. 3 or 4 eggs a day because they need protein. Most of them don't eat. They're old, their appetite is lost, and they're malnourished. And the other thing is zinc supplementation. So with all this, I managed to heal. I don't have patients because of this. They get better. So very little patience for me.
Any more questions from Dr. Wirithamulla? So in the absence of any more questions, I think we should close up the session. But before that, I, on behalf of the President of College of General Practitioners and the Council, I thank Dr. Himaru Wirithamulla profusely for spending his precious time with us, especially on a long weekend like this, and giving us very valuable tips for our practice. That will definitely help us, and we hope to see your collaboration in the future to come. Thank you so much. Thank you, Dr.
Thank you. Pleasure is mine. Thank you so much.
And thank you to all of those who joined us in these sessions. So see you in another webinar. Thank you so much and good night. Thank you.
Pleasure. Thank you so much.
Bye-bye.